Should we start, Dr. Hassel, or you want to introduce everyone?
Oh, I think it would be good to introduce everyone so that Yun Xiao meets everybody. So I'm Dr. Hassel, general surgical pathologist, do GYN and GI mostly at the University of Oklahoma. Felicity?
Hi everyone, I'm Felicity. I'm based in Washington, D.C., and I'm a grad student here. And I am Open's executive assistant.
And Yun Xiao?
Yes. Yeah, my name is Yun Xiu. Right now, I'm the first year resident at University of Missouri. So yeah, I'm very interested in learning more.
Great. So are you with Arun? Are you in
Uh,
what city are you in?
University of Missouri, the resident program, first year
So
resident.
is that a one in Columbia or in?
Yes, Columbia, yes.
Oh, okay.
That's exactly the place I'm
Okay.
living.
Great. Chen Yan?
Hello, everyone. My name is Chen Yan. I'm a medical graduate from China. I'm a pathology applicant this year.
And Jining?
Uh,
Hi everyone, I'm Chining and I'm a medical graduate from Malaysia. Nice meeting you guys.
Great to have you. And Zhao, Dr. Zhao.
Hi everyone, my name is Jiao Wu. I'm a pathologist and dermatologist working at Kaiser permanently. Nice to see everyone.
And I think you're a pretty new mother, if I understand right.
Yeah.
oh,
Thank you.
Congratulations.
Mhm.
Okay,
Thank you.
go,
Sorry, I don't have a
go right ahead,
camera.
go right ahead, Jining. That's okay.
Uh,
Okay, we'll turn the time to you, Jinyan.
okay. I think Dr. Bui also attended the meeting. I so appreciate everyone. So I
uh,
just got my last minute update about the PowerPoint. If I also a beginner, very early training. If anything I make mistake, please correct me. Thank you so much.
hey, Jinan, do you want me to share the PowerPoint?
Oh, you got a new version, right?
Yeah.
Dr. Bui. Okay, so maybe I just use yours, and this afternoon I just use your comment suggestion last night, but I think your version is much better. So I will stop screen, and so you can share yours. Let me make sure. How can I stop?
Oh, okay.
Uh,
Just give me 1 second.
yeah, sure. So I'm still share the screen.
No, you are not sharing.
Okay, maybe yeah. I stop screen sharing. Yeah. Yeah. Got it.
Okay, can you see it?
Yeah.
Oh. Oh. You can present the case and I can help you with the differentials and other part of the presentation. Is that okay? Can you hear me?
Yes, please do that.
Jian Yan, you are muted.
Oh, I'm sorry. Okay, thank you. Today I'm going to share an interesting case, and this is a 12-year-old boy with long-standing moles on the left calf that has recently changed, but there's no history of malignancy, family history, or the family history of melanoma. Yeah. From here, you can see the mole. And this is pretty much the low power. And from here, we may appreciate that there's some, the veg shape and also some plexiform shape and from the low power. And also you can see the lesion is pretty deep. It's in this is epidermal, right? It's pretty in the dermal and the subcutaneous layer. Yeah.
Yeah, it's pretty much in the dermis. Yeah.
Yeah. And this is a high power. From here, we can see some melanocyte mixed with melanophage. And also we can see there's some greenfish cytoplasm. And also we can see there's some sclerotic stroma. And yeah, I also, there's some a few maybe inflammatory infiltration. And this is pretty similar with the previous slides, it just in different area. Yeah. And from here, we can see some episoid cell or some the shape is, how did you describe the shape is a lung, Dr.
So here you can, yeah, like somewhat epithelial cells with unclear borders, and the nuclei are brown to falciform, pinpoint nucleoli, like pale gray cytoplasm. Yeah.
Okay.
And here you can see dermal mitosis.
Yeah, few of them. Yeah, thank you. And this is an open differential diagnosis, maybe including the cellular blue nevus and also the vent-active deep penetrating plexiform nevus dash melanocytoma. And there's another one we need to think about is pigmented epithelial melanocytoma, and also the derm melanoma. Yeah, primary with metaplastic. Yeah.
So pigmented epithelial melanocytoma, usually we see very heavy pigmentation with abundant melanophages, and the tumor cells are moderate to severe atypia, and the lesion usually very infiltrative. So we probably can exclude PEM from the differential. And dermal melanoma, probably we also can rule out, given the patient is very young, he has no history of melanoma. The cytology is just mild atypia, and only one dermal mitosis are seen, and prime immunostaining negative and P16 show retain expression. Sorry, I don't have the P16 photo to show you. So the main differential diagnosis here are cellular blue nevus and TBN. So before going to these two entities, I will give you a brief review of classification and molecular features of melanocytic tumors. So similar to other cancers, melanoma develop from multi-hit process from a precursor melanocyte. When it harbor a pathogenic mutation, it will develop to nevus. And when nevus cells acquire second driver mutation, it will progress to intermediate melanocytic lesion or melanocytoma. And when melanocytoma harbor 2 or 3 more pathogenic mutations, it will develop to melanoma. About 70% of melanoma arise de novo from melanocyte precursor, and approximately 30% of melanoma associated in pre-existing nevus. So here is a list of nevi that you need to know: common or conventional nevus, congenital nevus, blue nevus, cellular blue nevus, SPIC nevus, and other subtypes of nevus such as halo nevus, dysplastic nevus, and combined nevus. Here is a molecular summary of different pathway in melanocytic lesions. Here you can see from melanocyte precursor, when it have a different kind of mutation, it will lead into different type of nevi. For example, a precursor acquire NRAS or BRAF fusion, it will develop to common nevi, also congenital nevi. And when a precursor acquire GNAT, GNA11, cis-LTR2, or PLCB4, we will have blue nevus or cellular blue nevus. Yeah. And on the right, you can see a melanocyte somehow acquire MAPK fusion or kinase fusion. It will develop to SPIC nevus. And the nevi, when it's acquire 2 or 3 more pathogenic alterations, it will develop to melanocyte and then melanoma. So what is melanocytoma? Melanocytoma is intermediate melanocytic lesions that have some atypical features, but not enough to diagnose melanoma. There are 4 subtypes of melanocytoma in current WHO book that I listed here. They are including BAP1 inactivated melanocytoma, pigmented epithelial melanocytoma, or PEM, or BRCA1A inactivated melanocytoma, WNT activated or deep penetrating or plexiform nevus melanocytoma. And the last one is MITF pathway inactivated melanocytic tumors. So back in the day, melanoma was classified based on the histopathologic features and clinical findings. There was 4 subtypes: superficial spreading melanoma, lentigo malignant melanoma, acromelanoma, and nodular melanoma. And all these 4 subtypes were considered as one entity. So recent years, we have seen so many papers about melanocytic features of melanoma, and we learned that melanoma is quite very complex. Like several years ago, WHO released a new classification of melanoma based on the UV exposure or cumulative sun damage and molecular driver alterations. There are 8 subtypes in total. The first 3, including low CSD or superficial spreading melanoma, high CSD or lentigo malignant melanoma, and desmoplastic melanoma, are associated with UV signature mutations. And the other 5 subtypes, including SPIC melanoma, acromelanoma, mucosal melanoma, melanoma developing congenital nevus, and blue nevus, are not associated with UV exposure. And here you can see each subtype have specific mutations. About 5 to 10% of melanoma is associated with syndrome of familial melanoma. The most common one is CDKN2A, and others mutations including CDK4, BAP1, TERS, and so on. Now we go back. Now we will talk about 2 entities, cellular blue nevus and DBN. Hey, Jingwen, you can do the presentation.
Okay. Yeah, this is our differential diagnosis cellular blue nevus, and this is usually occur in children or young adult and female predominance. And this there you can see it's heavily pigmented black blue nodules or a plaque. Yeah, next please. And this one you can see the blue neva usually it's in the supra layer lesion, but sometimes it can go very deeper, I mean, to the derm or the subcutaneous. And usually you can see they're very, they have some border, you know, they push very hard and form this kind of folder. And yeah, and do you have any comment, Dr. Pui?
Yeah, it's also blue nevus or cellular blue nevus arise from the dermal melanocytes, so we don't see junctional component. And usually we see like dumbbell-shaped lesion, like variable pigmentation. Yeah.
Okay, thank you. And here you can see there's some, this is the cytology. You can appreciate that the cellular member is pretty smooth and also have small nuclear oli. And also there's some sclerotic stroma. Can we describe in this way? And yeah, I think basically you couldn't see any mitosis and the other thing, right?
Yeah, usually we don't see dermal mitosis in cellular blue nevi. Yeah.
Okay.
And yeah, the melanocyte admits with melanophages. Yeah, it can look very similar to deep penetrating nevus.
Yeah. So this is DPN. So usually it's can be seen in the adolescent and young adult, and it's often show up in the head and neck, back, and proximal extremity. And our case is in the cuff. And as here you can see, this is a kind of irregular and dark brown to black papule or nodules. Yeah. And this one, you can see there's some,
So this is a low power view of a TBN. On the right, you can see the deep penetrating nevus, and on the left, you can see conventional nevus. So the TBN is the dermal bay lesion, somewhat wedge-shaped. Here just show the lesion at higher power. Yeah, you can see pigments in the lesion. And then high power view to show the cytology. Do you want to describe the tumor cells?
Okay, from here you can see the tumor nuclear looks like a spindle shape or ovoid. And also there's some spindle shape. This one I think is like round. No, can you see this is round and also have some bubble in the nucleus?
Yeah.
And we can see some melanophages cells and mixed with melanocytic cells.
Yeah.
And also there's some stroma, sclerotic stroma.
Probably not in this lesion.
Okay, thank you.
So this is a simple chart to show you genetic evolution of TBN-like melanoma, so you have a better understanding of DBN. So it's similar to other type of melanoma. It's a multi-hit process. Precursor melanocyte harbor BRAF and RAS or BRAF fusion will develop to a conventional nevus, and nevic site acquired CTNNB1 mutation will develop to DBN. And when DBN acquire CDKN2A third or other mutations, it will develop to DBN-like melanoma. So this is a BRAF immunostain in DBN, and you can see BRAF show cytoplasmic expression in both conventional nevi and conventional nevus and the TBN. component here. Here is a beta-catenin. So I just show you that DBN is associated with CTNNB1 pathway. Beta-catenin and LEP1 proteins are downstream protein of the CTNNB1 or ACP pathway. So we can use beta-catenin and LEP1 immunostains to support the diagnosis of DBN. So this is a beta-catenin immunostain in DBN. And on the top, you can see membranous staining in conventional nevus is considered normal of DBN, beta-catenin staining. And on the bottom, we see cytoplasmic and nuclear staining in the DBN. This is so only nuclear staining is considered positive. And we have to see nuclear staining to call it DBN. Here the LEP1 immunostain, it shows nuclear expression in DBN components. LEP1 immunostain is not entirely specific for DBN. It can be positive in about 30% cellular blue nevus. So we have to use it in cautious. So this photo is just to show you that a small subset of DBN can express PRAME immunostain. So when you have PRAME positive in DBN, that doesn't mean melanoma. So go back to the lesion. The main question is cellular blue nevus or DBN. So here the beta-catenin staining in the lesion. So here you can see nuclear and cytoplasmic staining in the lesion. So the final diagnosis is the DBN. Yeah, here are references. Thank you. We're happy to take any questions or comments.
So I have a question, Dr. Bui.
Mhm.
Okay, so I think sometimes the navy or the benign melanocytic lesion may be hard to differentiate with the melanoma. So especially you cannot see obvious invasive part. So my question is, how if we find some lesion, so how can we differentiate from benign nevi and melanoma?
Also, so you can, based on the clinical presentation, it's one thing. So usually melanoma will show irregular border, different color, like a large lesion, and for microscopically, melanoma tend to look very ugly, and without maturation, we see many dermal mitosis, right? You also can use immunostains like PRAME, B16, HMB45, and Ki67. So PRAME tend to be positive in melanoma and negative in nevi. B16 usually show loss of expression in melanoma and demonstrate retained expression in nevi. HMB45 usually positive in the top of the nevi, but negative in the bottom of the nevi. But HMB45 usually positive in melanoma, the whole lesion. You can use Ki67 to highlight dermal mitosis in melanoma. if you cannot make a decision, you can think about molecular studies, for example, CGH or like NGS. Yeah.
Okay.
To look for abnormal copy numbers or third mutation or like CDKN2A mutation. Yeah.
Yes, thank you for that. So you just mentioned the beta-catenin may be very useful in differentiate the benign lesion and the benign lesion and the malignant melanoma.
So beta-catenin is very helpful to distinguish DBN from cellular blue nevus.
Oh, okay.
Yeah.
How about the expression pattern of beta-catenin in the melanoma?
So for example, if you have a DBN like melanoma, you will have positive beta-catenin. That means nuclear staining pattern of beta-catenin.
Okay, thank
Oh,
you.
sorry, it's not CDKN2A, it's CTNND1, CTNNB1. Yeah, like this. Yeah.
Okay, so yeah.
But so we don't really use beta-catenin as a marker to distinguish benign versus malignant in melanocytic lesions.
Okay.
Yeah.
Okay. So I have another question. I think right now we have lots of genetic tests on lots of lesion, including the benign lesion. So for the melanocytic lesion, we can see from the precursor melanocyte, we can get a bunch of mutation, and later on, maybe on the latest stage, we got additional mutations such as CDKN2A or TERD. So if we got, you just mentioned CDKN2A and TERD. So that's those are maybe if we found those mutations, we can feel very confident to report that's melanoma.
Yeah. So there are a paper, I think it published a few years ago, saying that if you find at least 3 pathogenic mutations or abnormal copy numbers, yeah, it's pretty much like melanoma. Yeah.
Okay, thank you.
And CDKN2A is one of them. Yeah.
Okay,
So you know CDKN2A associated with P16 protein. Yeah, that's why we use P16 to help distinguish nevi from melanoma.
Okay, got you. Thank you. So helpful.
So Dr. Bui, can you hear me?
Yeah, I can hear you.
Yeah, I just a follow question. So I don't have any training experience. I'm just the pathology applicant this year. So I just want to know. So for the genetic evaluation, is routinely used in the real practice to diagnose? It's routinely used for the in the practice, in the real practice.
Yeah, we use immunostains a lot. Molecular studies, sometimes, yeah.
I'm just wondering, so in this slide, the first hit is a lot of fusion mutations. So it's common in the to use in the clinical practice, or just use the immunostaining that
Yeah, I don't know. I think immunostains are very common. I think moleculars is we do it sometimes when needed. Yeah, because it's pretty expensive. Yeah.
Okay, got it. So that's okay. I just wondering, the genetic evaluation is so it's just okay. It's not that important, not that basic. Just for further maybe for narrow the differential diagnosis or for the final diagnosis for the complex case.
Yeah. When we have a very challenging cases, yeah.
Okay.
Mhm.
Good. Thank you so much.
Yeah.
You want me to add a couple of things?
Yeah, I was
Yeah,
First
sure.
of all, I was going to ask Dr. Bui if you were willing to share your slides with us. There were some tables in there that I liked that I would
yeah,
like
sure.
to have, if that's
Yeah.
okay.
Yeah.
And
Yeah.
I also practiced at Kaiser, but I'm in Northern California. I'm not practicing now though.
Oh,
But
I see.
yeah. So anyway, just a couple of thoughts on this case. You shouldn't feel bad if this is a little bit overwhelming, because this is probably one of the more complicated cases you're ever going to see. And especially with all of the immunostains and the molecular studies and everything. When I got into practice, a lot of these unusual nevi, like for instance, deep penetrating nevus, which was only described like in 1989, and a number of other nevic variants, were all just called melanoma if they were unusual. So the vast majority of cases you're going to see are not going to be like this. They're going to be either a benign conventional nevus or a more obvious melanoma. One of the things I always found helpful is to keep in mind that the diagnosis of melanoma versus benign versus malignant is always dependent upon a lot of factors, clinical and histologic factors, sometimes stain results and things like that. And it's also context dependent, meaning there are certain criteria that you may hear, oh, well, a nevus is well circumscribed and a melanoma is, poorly circumscribed. But that doesn't necessarily apply, or say symmetrical. For instance, a nevus is symmetrical and a melanoma is asymmetric. But if you're considering like a blue nevus or something like that, the symmetry is not the same. Or you might say, oh, cellular atypia would indicate a malignancy. But if your differential diagnosis or your context includes a Spitz nevus, well, that's almost by definition has atypical cells in it. So you need to rely on other factors. So, and even age, Dr. Bui mentioned that this patient was 11, and so melanoma was unlikely, and that's true. But melanoma does occur in young people. So I never use age as the only criteria to say it's unlikely. What else? Let me think here. Yeah, I think that was about the main thing I wanted to mention. The other thing I thought was interesting was your first clinical photo of the thing. If you want to go back to that,
Sure.
It's always good to be aware of the skin type, because in addition to the lesion, one thing I noticed in the skin is the background skin is very pale skin with a lot of freckles. And that's a high risk skin type for melanoma. So that's one reason that it's nice to know the skin type. That's called Fitzpatrick-1 skin type. And the other interesting thing about that is that when you get a re-excision of melanoma in a person that has that skin type, it may sometimes be hard to say there's a clear margin if you're not careful, because you're going to actually, if you cut an ellipse through one of those freckles, you're going to see melanocytic proliferation. And if you don't know the skin type, you can say, oh no, you're still there at the margin. You have to go back and get more. You get more. And you may end up chasing a lesion. It's more likely to occur in older individuals. In fact, this skin actually looks like it might be an older individual, although it says it's a 12-year-old boy. So anyway, it's interesting if you get the chance to look at clinical photos of your cases. That's often helpful and it's educational. I think that's about all I wanted to say, but just to leave you with the thought that this is really one of the most difficult cases you could possibly look at. And even as an experienced dermatopathologist, I would be showing cases like this around to others.
Yep.
Awesome. Well, thank you, Janyan, Dr. Bowie, and Dr. Bakocha. Do we have any last comments or questions before we end?
I just want to show my appreciation to Dr. Bowie and help me deliver this wonderful presentation. I learned a lot during this process. Thank you so much. Yeah, Dr. Bowie. Yeah.
Yeah, you are welcome.
Thank you. Bye-bye.
Bye.
Thank you. Thank you, everyone.
Bye, everyone.
Thank you so much. Thank you. Bye-bye.